Mauro Segura.
Yes.
You can share your screen.
Yes, I do.
Thanks again, Matthias. I think we will have some questions at the end of the session.
Thank you very much. Can you see the screen? Yes, I guess.
Not yet.
Now?
Yes. I think we will see.
Okay.
Yes.
Thank you very much again, and thank you to the organizer for this beautiful webinar. And after the beautiful presentation from Dr. Matthias, it's very easy for me to continue with the topic microvascular decompression for trigeminal neuralgia. This is my college, Mario Alexis del Real. We are working in Morelia City, Mexico. I want to do a brief introduction because this is also for young neurosurgeon, because this is a very important topic, and I call this is a strong fight against philosophy and understanding of neurologists, algologists, and other medical specialties. So we have to teach them that it's a really area of the neurosurgery. Of course, we all know the previous name was described by Janetta many years ago as dysfunctional syndrome. It's a hyperactive dysfunction cranial nerve syndrome. And after the times pass, we move or we change the name, but it's not only neuralgia. It's not only fascial pain. It's not only trigeminal neuralgia. It's a very complex disease. So this is the problem. One of the problem, the main problem, as Dr. Matthias said, the most important and most frequent cause of the trigeminal neuralgia is the vascular compression, as Professor Janetta said, but also there is another factor, as I will describe. In our experience in the last review, we found this number of cases, 486, and most of them were mixed vascular, venous or arterial type. And some of them only venous, 11%, and some of them one artery or two or three arteries, 16. But the most important I want to the young people pay attention is that the MRI is only important to find the tumor cause of trigeminal neuralgia. It's very less frequent, 10% around, but it's very important to find a small or big tumor, a benign tumor like a epidermolysis, or malignant, or not some aggressive tumor. But that is the point for the MRI. No matter is 1, 3, 9, whatever Tesla, it doesn't. It's not important to do the diagnosis. The diagnosis is only with the clinical data. And of course, we know this picture from Dr. Rotten, but I can say that in the last 22 years working in this small area, there is no a single pattern. There is no easy to find a pattern. It's as much variety as much as patient we have. In general, the most frequent, as you know, it's B2, B3, and that's why the odontologists have a high responsibility to diagnose and to deliver the patient to the neurosurgeon. Okay, so as we can see, this is our experience from this hyperactive dysfunction syndrome from the last 10 years, 1 decade. And I'm going to focus on this primary trigeminal neuralgia or primary hyperactive dysfunction syndrome. And we have to pay attention and also this classification, the classical type, the most frequent as all we know, and the idiopathic type, and other time called the atypical type, but it's about 10% of the old cases. It's also important to recognize that in most of the cases is the same pathophysiology, the same cause, the same etiology. So we found this general data for classical trigeminal neuralgia. Of course, 3 to 1 female to male. The size is not important, but the important point is that up to 8% will become bilateral, not in the same time, but during the long lapse. In some cases, as we know, we have to do the operation at the same time simultaneously. And the average for the age, the patient, is between 47 to 55. Okay, this is general technique, as also present Dr. Matias, but this is not the moment to discuss. We prefer the cubitus position for normal weight, only the head rotation, and for morbid obesity, we use the Parvane or very a complex position, but lying position. Also, the landmark was also Dr. Matias explained, and I'm going to show this video. This is right side, retrosigmoid approach, infrasternal craniectomy. I want to focus, never do it in the asterion. Even the name is asternal approach. We never use the asterion as the first point. And this area corresponds to the sigmoid sinus. This area corresponds to the transverse sinus. This is the angle. And for us, it's very important to discover the roof, the sinus always, in order to take control of this angle and also the other angle on this point before the jugular gulf. In average, 2 centimeters diameter is enough to do the surgery, as you can see. And the second tip that we recommend is not open the dura in the curve line, but we open this triangle shape, sorry, and that is enough space to go into the zero-pontine angle. In this point, it's very complicated sometimes to do the coagulation. Also, we need the Mackenzie clips or some treatment for the bleeding from the sinus. And in the next, it looks in the same, but it's different also. Right side, this is the base, the sigmoid sinus. This is transverse sinus. And also, you can see in this green shape, the dura opening. And in this case, it's an obtuse angle. I'm going to go back and stop. And as you can see, there is no clear rectus angle. There's no 90 degrees angle. It's maybe 60 degrees. So in this case, we open the dura in star shape, like we show. And also, that small space is enough to go to the contour angle. As you can see, we never use retractor. It's not necessary in this position, only with the liquid drainage. I will show some examples. In this case, it's a right trigeminal neuralgia. It's very easy to go to the area, anatomical area described before. You can see clearly how is the vascular contact and application of the Teflon. And one point, I guess this is a old video taken from me and my college, but in the present, in the last years, we prefer use less Teflon and to put away from the nerve. In the last decades, 2 decades, we have found a couple of granulomas. It's a long time complication after the Teflon is invaded for the fibrosis. So up to date, we prefer also the same material, but collocate just from away to the nerve. This is a review. We call this in 180 degrees to the right and 180 degrees to the left. It's impossible to do it. This is the TC. It's impossible to do the revision 360 degrees. It's just technical note. And in this case, as you can see, this is a patient with morbid obesity, more than 40% of overweight. And I want to show this. That's why the picture. Just the adipose panicle was about 4 centimeters, 1.5 inch. Sometimes the instrument is not enough or can complicate the surgery. After that adipose area, of course, there is another region, the bone region. It could be also 1 up to 2 centimeters. And in the pontocerebellar angle, it's very easy to treat the vascular element. In this case, we collocate the Teflon. And it seems to be easy, but it's not. Next sample. I want to emphasize because a friend of us is looking from Spain and has some many cases from multiple sclerosis and trigeminal neuralgia, of course, is very known for us neurosurgeon working in the skull base and working on trigeminal neuralgia and with experience. But for most of the general neurosurgeon, for neurologists, for allergologists, for ontologists, they don't know that the half of the patient with multiple sclerosis have a vascular compression. Of course, as you can see in the video, there is a demyelination, there is an atrophy from the nerve in this area, and you can see we are removing. Also, this is a normal arachnoiditis, like a viscous. You can see the nerve looks like fillets, very separate between them. There is no surgery before. There was no gamma knife before. And beside that, of course, the patient have vascular compression. It was removed. Another example, also is very common for us. In Mexico and Latin America, we can do this surgery very common. Patient with more than 70 years old. 20% of our cases have more than 70 years. And in US, it's a criteria for not operation or for not to go to the operation room according to the American guidelines. However, for us, it's a simple surgery. It's very easy. There's a long, huge space, cisternal space. You can see the nerve cistern segment. This patient have complex vascular compression, multiple vascular, venous, and arterial. And she was operated a couple of weeks ago. And of course, you need a very intrepid anesthesiologist and technology to do the monitoring and also the to avoid or to take care for another comorbidities as diabetes, cardiopathy, hypertension, for example. And finally, one more example we see in the previous presentation, patient with vertebrovascular dolichoectasia is not so rare. We have dozens of patients with this situation. As you can see, this is the nerve clearly compressed. For this is the, again, sorry, right side. This is upper side. This is the superior cerebral artery, and this is the tiflum. But after that, we are going to treat the vertebrovascular dolichoectasia. In this, I will stop. Here is the trigeminal nerve. In the first step, we separate the supracerebral artery, and here we are doing the link technique or proposed by Dr. Morcos. This is latex, and we are going to put some clip. We are remodeling. It's called the transposition of the vertebrovascular complex, and collocate a clip. In this case, was a couple of clips in the petrous bone here. And we stop because it's important. You remove this, you transpose here. You can look this space. The nerve, the basilar artery, and after the remodeling, we are going to obtain a free space here. And stop. Here is a free space without contact from the vertebrovascular artery. This patient was delivered yesterday. This patient is a young man with a expectative life, maybe 3, 4, 5 decades. So we don't want he come back shortly. And other clip. And after that, we are going to protect the clips. Of course, mini clips looks young, but it's a very careful surgery, less than 2 centimeters. You can see the space. And the day after, the patient was completely free of pain. A little TC, and this is the approach. 2 centimeters is important. We never, I want to say clearly, we never do this surgery without all the elements. Midas, it's very important. Drills, microscope, clips, Mackenzie, many micro scissor, many bipolar. Incluso we are doing a modified capa bianca in order to reach some deep veins. And after that, the closure is the same as we know. As conclusion, but not my conclusion, but recommendation in this case, in my country in Latin America, of course, if we have another opportunity in the future, we can talk about the result, the outcome. We are working with the Professor Campero, Professor Matias, with a follow-up in this with all patients in these countries. Approximate up to date 5% of recurrence in a long time, not in the short time, but in the long time. I'm talking about almost 1 decade. Surgical malaria of trigeminal neuralgia, it's matter of the high-level neurosurgical center. It's not for resident, it's not for first, second degree resident, it's not for the last time schedule in the peritoneal root surgery. It's as much important as meningioma, as aneurysma, as another brain surgery. Thank you very much.
Thank you, Professor. We are running of our time. Could you answer